being to those of you in the room and those of you on joining us online. Can I please start by acknowledging that we are meeting today on the unceded lands of the Wurundjeri people of the Kulin Nation, pay our respects to their elders past, present and emerging, and acknowledge the importance of Indigenous knowledge to the academy. On behalf of myself and the other directors of the Collaborative, Professors Megan Munsey and Marie Bismarck, I welcome you to this evening's event and thank you for joining us. So as many of you know, the Collaborative for Better Health and Regulation is an opportunity for us to come across from schools, disciplinary areas, to understand how we might better regulate to enable improvements in care, individual care and also public health. Our aim is to do our bit in helping to establish Australia as a world-leading example of a governance environment that's capable of supporting trustworthy population health, quality healthcare, medical research and healthcare innovation. Because we know that good care requires good governance. So the issue we're considering tonight is a very good example of that. It's an area where if we don't get the governance right, then we are going to undermine the potential to improve individual and population health outcomes. So we're going to be considering the use of genomic sequencing or molecular analysis to track and trace the transmission of disease across the population. Now, the technology is one that became more familiar during the COVID-19 outbreak. At that time, it helped us to understand how that particular disease was spreading. The same technology that we're going to hear more about shortly can also be used to identify transmission pathways for other diseases, such as HIV. Now, we're going to hear some of the public health advantages that follow from a more granular understanding of transmission. Being able to map the transmission pathways at an individual level allows us a much finer-grained understanding of how the disease is spreading, and that can powerfully inform a public health response. But of course, mapping HIV transmissions at an individual level raises a number of both legal and ethical challenges. This collaborative event brings together a number of panellists with expertise and lived experience relevant to the issues, and it's a group of panellists who previously came together to form an interdisciplinary collaboration to consider those ethical and legal challenges. So we'll be hearing from them about what they think should be done, but we'll also be hearing from them about what their experience was of addressing a policy challenge such as this from a genuinely multidisciplinary perspective. What did that experience reveal about how we should be trying to formulate policy and regulate in this space? So the speaker bios were circulated with the invitation to the event, but to briefly recap, we joined Professor Louise Keeler, a health sociologist in Melbourne School of Population and Global Health. Louise is an expert in qualitative research that explores the intersection of ethical, legal and social issues related to contentious health technology. Dr. Jerry Brophy is a health sociologist and qualitative researcher in the Centre for Health Equity at the Melbourne School of Population and Global Health. Her research interests include social and ethical issues associated with new and emerging biotechnologies and sexual health. Richard Keane is the Chief Executive Officer of Living Positive Victoria, the peak HIV support and advocacy group in Victoria, representing all people living with HIV in Victoria. Dr. George Collborative is an academic and public health professional based at the Doherty Institute for Infection and Immunity, focused on the diagnosis and characterization of priority infectious disease. Casey Hayden is an interdisciplinary researcher with qualifications in biomedicine, population health, and law. Her research explores the regulation of sensitive areas of health, such as sexual and reproductive health and genetics. We were hoping to also be joined tonight by James Hamlet, who's the Senior Policy Analyst at Thorn Harbour Health and an HIV community advocate. Unfortunately, James is not well tonight and won't be able to join us, so we wish him our very best wishes for speedy recovery. Here was Sue James. But I'm sure that you will all agree this is the perfect panel to be discussing these issues. And once they have presented for a few moments on the collaborative and their experience addressing these issues as a group, we're going to have a discussion moderated by my friend, colleague, and co-director of the collaborative, Professor Ian Munson. But we're going to start, I think, with a presentation by George. So, over to you, George.
Thanks very much. Hello, everyone. So, as mentioned, my name is George Harrow. I'm an academic mainly at the Doherty Institute with a background in biochemistry, strangely enough, but I've been working in genomics and public health in the last few years. And would like to just present more of the technical side of this project coming into it, and then leave others to discuss introduce more of the public health and legal and ethical aspects. But this is my clicker, we've done this background panel. So this was my first slide, and I just wanted to start with more of a statement of facts, just to kind of set the scene. And that statement of fact is that viral sequences carried by people living with HIV can be used to understand interactions, shared exposures, and transmission. This isn't up for debate. This is something that is possible with current technology. We can look at viral sequences and look at how related they are between individuals that carry those viruses and say, do they maybe have a shared exposure or not? If they're very similar, maybe they do. If they're very different on a genetic level, then they likely don't have the same exposure and they're not part of the transmission pathway. What that might look like, and to kind of give you a few examples of what our project showed, is things like this. This is an example of a transmission network or transmission pathways. And so each little node is an individual's HIV sequence. Everyone has a unique HIV sequence that represents the HIV that they carry, that they're infected with. And the connections represent how close they are. And so some individuals might not be connected to anyone that we know of. They might just be standalone. They might have acquired it internationally or interstate, and there's no known sequence that is close to that. Versus others that represent really complex networks that are so intermingled and unable to be kind of teased apart to say potential transmission within that. And so this would represent a really large and complex transmission network. And then you see kind of different levels of transmission as you go across. This is all possible on a sequence level, but we can also, with public health professionals, overlay relevant metadata is what we call that. And so this could be things like risk category, if someone's engaged in certain sexual practices or if they're an injecting drug user, that type of thing. That might then explain some of that exposure that they have. And so once we overlay that data, we can see potential transmission groups that are more likely explained by certain risk characteristics, say injectable drug use. And these, once we've identified that, we can act accordingly and maybe tailor certain public health measures or individual level access to resources that are specific to them and their risks. So this is something that has been done internationally before we formed this collaboration. It was something that we wanted to consider, do we want to do this? Can we do this in Victoria and Australia more broadly? But from the get-go, we really wanted to have community engagement and involvement. And so as part of this collaborative, that was the kind of nexus of this team that you see on the panel. So to bring together that relevant expertise, but also that community perspective. So a lot of this information is described in a paper that was published earlier this year in the last Regional Health. And through that paper, we took a very research focus, a de-identified approach where we didn't have any individual kind of identifiers, any of the sequences that were part of the study. And we analysed the data for Victoria for 20 years to then say, what could this have shown us if we did have identifying features through that data? Could we say, is this individual part of a growing risk group or transmission network, or are there certain things that we could have done in this de-identified approach to then say, if we did make this identifiable, if we did link this to an actual patient with, a public health response, what could that look like? And so this is my last slide to do with data. And this for me is a really salient example of how this changes the game from traditional public health responses. And so these at the top here are 3 different transmission groups. Each of them are quite large. They're around 80 individuals. And what that very top left panel is showing the distribution of those samples over 20 years. For the top one, you can see there was a small number, and over time it increased dramatically around 2015. I took the axis as not, sorry, that should say 2015 about when that little hump at the top goes. I might have a quick look up here. Yes, up here is 2015. This transmission group here, it's really stable. It just kind of bubbles along in the community. It doesn't increase dramatically over time. Versus this transmission group, which really didn't exist in Victoria until about 2015, and then it really took off. What I would consider an outbreak. It's something that wasn't in the state and all of a sudden is now here and causing a large number of cases. What's interesting is that across these three groups, there's really no distinguishing feature if we look at traditional epi data. They're all, or largely men, they all largely have MSM as their risk category. There's very low levels of drug resistance. They're all young men. The place of acquisition is largely Victoria, and they're all the same subtype of HIV. So based on traditional epi, there's absolutely nothing that would separate these out. They all look like they could be the same transmission network. But from a molecular level, we can see that there are three different ones, and there are three different patterns of growth and decline over time. If we then take that and do some rather complicated modeling to then say, when these areas of growth and decline actually occur, this is the first group, the second, and the third. And I'll draw your attention to this one, where there was really no growth up until just about 2014, and then it increased dramatically. So there was one period where this group wasn't contained, where there was a clear outbreak, where if we could identify that early, we could resource the relevant communities, we could make sure that people were able to access testing and make sure that their broader social networks or potential contacts were brought into that health system to make sure that they were diagnosed if they did carry HIV and able to access relevant care and the like for that. So this is interesting and new and not possible from traditional epi, but it's also, I'm sure we'll touch on in a moment, fraught with ethical and legal concerns. Just to sum up my perspective on what we're about to talk about, the role of modelling for transmission and HIV control, it can complement traditional approaches. It's part of the package that we could offer. It can really complement it. It can allow for prioritization of public health resources. So in our current public health setting, it's very much about prioritization. There isn't limitless resources. We can say we're going to give resources to communities that are experiencing outbreak or really need it now, if that's something that the public health system really needs. Ideally, we would have lots of resources, but we're trying to work with what we've got. And then lastly, this is more of a personal take, but it really requires community support to be both ethical and effective. We can't be making these decisions outside of the environment the community has to say. And so this is the summary of our project partner site, just as logos rather than individuals, but we're a group of academic groups. So the Doherty Institute, which is a joint venture between the University of Melbourne and Royal Melbourne Hospital or Melbourne Health, the University of Melbourne, Victorian State Government, who are partners on the grant, Vigil, or Public Health Reference Laboratory, where a lot of the traditional HIV sequencing work was done, and then a number of community partners who have been absolutely huge throughout this project, and I can't thank them. I will then pass on to the next speaker to talk more about community partnerships and kind of historical context there.
Okay, so I probably don't need to look at mine, just a little bit of history. This has been going on, these discussions around phylogenetic track and trace has been going on a long time before the grant was engaged. Originally, when it was discussed with us, Thorn Harbour Health, and unfortunately James can't join us tonight because of ill health, Thorn Harbour Health work and are funded in the prevention space around HIV, and we're going to align in a full partnership with the Doherty. Both myself and Dr. Kirsty Macon from Positive Women Victoria, who's their executive officer, decided that we wouldn't be full partners in that. We felt like the implications and the outcomes for people living with HIV around potential criminalisation and ethical issues around the use of this technology might mean that we need to advocate outside of that partnership in a really strong way. So what we did after a little bit of a talk with Professor Sharon Lewin, and you can't kind of not kind of come in on the game when Sharon's kind of leading it. We've had a very long and productive relationship with the Doherty Institute over many years. We decided to write letters of support to support this grant and further investigation. It's been fantastic to be meaningfully involved in this discussion that's taken a lot of different twists and turns over the last 2 years, and it's kind of coming to a conclusion in December. I was really interested at the time frame that you were looking at, that increase around 2015. That was prior to PrEP coming in. which is a biomedical advance which helps prevent HIV. It's a medication that's taken by at-risk individuals from MSM populations. I'm not sure if we have the same kind of level of spike now. And I guess from my point of view, I think this technology changes the way and some of the huge successes that we've had here in Australia with the HIV response, where it has always been community and individually led. So I'm talking historically about condom use in prevention. Then I'm talking about positive people participating in clinical trials, putting their bodies on the line to develop new and effective treatments, watching those treatments get better and better over the years, biomedical advances in prevention. We just talked about pre-exposure prophylaxis, post-exposure prophylaxis, now long-acting injectables. There's a whole range of factors that have got us here that kind of put the onus back on empowering the individual to take control of their own health. And we believe that this sits above that and does it different. It looks at a population basis that sits above that individual responsibility, but has potential ethical and criminal outcomes for individuals if it's applied at the public health level. So they're some of our key concerns. And we've had a really good opportunity to kind of work those through, and we'll probably unpack a few more of those things as we kind of have a little bit of a chat through this evening. But my key concerns are, again, not just the criminalisation, but the potential for stigma for the marginalised communities that I think will be represented in this data. I think so far this has been used in criminal cases in Queensland back in 2016 and was a contributing factor in the outcome of that individual who was a heterosexual man from a migrant background who was imprisoned and then had to leave Australia because they were a migrant here and had to leave after they got out of prison. I am concerned that it will impact heterosexually identified men, women living with HIV who may not know that they've been living with HIV for a long period of time, and very real impacts on migrants coming to Australia. So students who are here, a HIV diagnosis and discovery in a cluster like this is great for our public health, but it has real life implications for their ability to stay in Australia and to receive the health care and other things that we've got. So we still have a whole range of concerns. We're yet to be fully solved, but again, I'd like to highlight the privilege that we have in this country of having an opportunity to have a voice at the table at every level of the decision-making process that impact our lives. I'm a person living with HIV. I was diagnosed in 1989 when I was 19 years of age, well before the first lot of treatments came around. So I've seen a lot of change, and I think part of our success has been what's on display here tonight, which is our community partnership across government, research, medical, science, and so thank you.
Thank you so much. Thanks, Mark and Megan, for hosting. So this grant was written in 2019, before COVID, and it had this incredibly ambitious plan, which I've just screenshotted here from the grant. So we had 4 years, and the plan was aim 1, a technical framework for implementing HIV phylogenetic research. Aim 2 was to develop best practice around sequencing and bioinformatics. And then aim 3 was to incorporate it into the public health system and evaluate it. And I took a quote from the grant that said it was both feasible and realistic. And this is how we write grants. So we do always promise a little bit, but this was incredibly ambitious. But it did have a fantastic set of partnerships, relationships were already there. It was led incredibly well by Sharon Lewin and Deb Williamson. Sharon is an extraordinary leader in bringing people together and keeping people on task, and Deb was incredible, but did move to Scotland halfway through the project, which also didn't help. And we had lots of personnel changes. The Department of Health people that we started with were not the ones we ended up with, but an incredible group. So despite all of this, we ended up with a really small group, not a smaller group than the original big group that started out, who worked really closely together along the whole way. And Jack, I should mention, as someone who also kept us very much in line the whole way along. So Jane Hocking, Kit Fairley, Edwina Wright, Kirsty Machen, Doris Chibo, James Hamlet, Colin Petrini from Thornton Harbour, Aaron Cogle was also incredible, and Brendan Quinn. But it became obvious to me early on. I hadn't worked in HIV and AIDS for about 15 years, so I had worked at it previously in my career, but hadn't done it recently. I think actually what they wanted on this grant was an ethicist, but they got me instead. But it became early on that criminalisation of HIV transmission was going to be a really key issue, and I don't think it was really mentioned in the grant much at all. So it wasn't like it had been built in as a core part of the research that we were going to do. But early on, so I think we started the grant in 21 in the end, and an event was held by Thornton Harbour Health, and I went along to see what the community perspective was, and all of the questions were about criminalisation, and it was very heated. And I was like, oh, hey, hadn't really predicted this. So we pivoted pretty quickly to make criminalisation a really core question of the grant. And AIM1 essentially became 3 separate projects, and AIM3 money got put into AIM1, and AIM3 didn't really happen, which isn't uncommon in grants. You have to be agile, especially when you're talking about something that's going to be in the public health system. Yep. So the qual research, so we were going to do some qualitative research with the community, which Jane's going to talk about, but that was never going to get us to a point where we could say, yes, the community are signed on. It wasn't that sort of research. It was to say, what are the issues? What are the perceptions? What do people think? We did a review of existing guidelines internationally, like what do we know about how this is managed in other settings, so we could know the key issues. And then we dedicated some resources to looking at criminalisation, which hadn't initially been planned, which Casey led and she'll talk about. And really, those 3 pieces of work get us to the point where now we could probably start thinking about an ethical framework. So, it wasn't possible to do it in the time frame that we had, but I still do think that the pieces of work that we've done have progressed us forward and are putting us now in a really strong position to think about what would you actually need in place if you were going to implement it. So I think I'm handing over to Jane.
So as Louise flagged, after she realised what was happening, she advertised for a qualitative researcher and she got me. So with a lot of help from Richard and other community partners, we developed recruitment materials to invite people who would potentially be impacted by this technology to share their views on the acceptability of what was being proposed, even though that wasn't entirely clear. So the upshot of that is that I got to interview 23 people, which in qualitative research, we don't sort of claim to be representative of a particular population, but we did get some really rich data to identify particular issues that people were concerned about or excited about. So in terms of this group of 23 people, there was quite a varied level of understanding of the technology. So a small number of people had a really strong understanding if they had a professional background in scientific fields. But we tended to find, again, this wasn't, this is not a sort of a scientific analysis, but we tended to find that the people who had less of an understanding were really quite positive about it and, very hopeful that it could be useful in getting closer to that virtual elimination goal. But there were 4 people who had really strong understanding. 2 of them were incredibly enthusiastic. 2 of them had very deep concerns that they were able to articulate at length. So we got a real spectrum of views. So I don't really have time to go into actually presenting that data, but we are finalising the write-up of a paper that has all the data in it. But just to go over the main themes, so what we were really trying to find out was what were the reasons people were supportive of molecular epidemiology and why were they less supportive. So in terms of reasons to support, there were ideas of, it was really good to, the more science can understand things, that's great. There were notions that it might lead to better public health interventions. So I think, as George sort of flagged the possibility of directing resources to a specific outbreak. But data could have an evidentiary value, so potentially it could be used to disprove transmission or because it's sort of getting to the criminalisation. So for some number of people, that was sort of a positive thing that we could use it to like get better legal outcomes. Whereas for other people, it was concerns around criminalisation cases that are going into that a bit more. And then there was always just the general promise of, gosh, well, if it'll help us end HIV, why not? So then in terms of not supporting, there was really, even people who were supportive had empathy for the idea that it may deter people from testing if there were concerns about how their data was going to be used. And yes, concerns about third-party access to data, so who would actually be the custodians of this data. And if it was the Australian government, there was some, recent high-profile examples of them not being particularly good custodians of personal data. So there were also concerns about marginalised groups bearing the most risk. So as Richard was talking about, international students, other communities who tend to be criminalised already. And also concerns around whether, in the context where we are kind of strapped for resources, is this just a distraction or will it actually do what it says on the tin, So those 4 reasons not to support kind of boil down to, does the risk outweigh the benefit and can it actually do what it's promising? So all of that sort of really just has brought us to think that a lot more work needs to be done to educate and engage marginalised communities to support meaningful community consultation, and that as yet the conditions aren't met for the ethical implementation of HIV in public health, HIV molecular epidemiology in public health. So I'll hand it over to Casey, who's going to talk about exactly these kind of legal specificities.
Thanks, Jane, and hi everyone. I came into this project as a kind of dig in and dig out. I was told, look at the criminal law and tell us some of the issues. And it was a really exciting project to be about because it's something that I kind of reviewed the framework and I thought, on paper, this sounds pretty good. But the issue is law on paper isn't how it translates in practice. And we need to think about that. We need to think about how regulation impacts implementation and how it can actually be used to, although it has stated goals to advance public health or protect the community, how it can actually not achieve that and in some respects undermine that. Now, when we're talking about this technology, as with most scientific innovation, there's always ethical and legal issues that we need to deal with. And often we're kind of, the law in particular, typically lags behind science. So science comes in and then the law is trying to catch up and then we're in this kind of dilemma. So we have the advantage now that this technology isn't being implemented in Victoria as of yet. And so we can look at the regulatory framework and think about that, what would need to be done so we can maximise potential benefits of this, so it doesn't undermine the public health benefits that this technology is trying to improve. There's also broader issues around privacy, around migration law, etc., but I'm not going to focus on that today because we've got an hour and a half. But I think what's really, really important is the criminalisation aspect, and it's, as Louise pointed out, and it was really coming out of Jane's data as well. So just, again, I'm working in high-level terms, and I'm really focusing here on the Victorian response to say that most jurisdictions broadly take the same approach, but every jurisdiction has a different flavour that they like to insert, and so they also kind of nuances. But broadly, when we think about the regulation of HIV transmission, we have kind of two approaches. And we've got the criminal law that engages and what we call the public health response. And that seems like a bifurcated approach, and to some extent it is, but there is interaction. So it's not the case that they operate solely in silos. So the public health response, as its name would suggest, is the aim or the goal of this type of regulation is to really focus on protecting the population. So operating with the population health, so we're minimising transmission for the betterment of public health. So how does that work? So the Public Health and Wellbeing Act has a lot of provisions, and among them is management of infectious disease. And we saw this in COVID. So they're not HIV specific, but they're looking at the management of infectious disease. And the goal there is there's a number of guiding principles, but the idea is that we take measures to minimise public health risk. And in establishing that, it assigns kind of administrative powers to particular officers, such as the chief health officer, to make public health orders if they need to. And they can range from kind of educative measures to more coercive measures to isolation orders, detention, etc. The idea about that is that you use the least coercive measures and you infringe on people's rights to less extent as possible. So you start up with the education. If they don't work, you escalate. It gets increasingly more coercive. That's not to suggest that you can't employ coercive measures directly. There is a risk, but the idea is it's a building. We educate, we get people into counselling, we minimise public health risks, and if that doesn't work, then we get more coercive. It's the same. So that's the kind of this is a 4-stage approach to climate management. Again, I'm not going to go into it, but it's the idea is you start with counselling, education, support, and you get increasingly more coercive. And there's different officers, and then when we're looking at more coercive measures, from the chief health officer, we have a HIV case advisory panel who has input on those cases. But the idea of the public health response is it recognises shared responsibilities. So it means that, we try and minimise transmission, we take reasonable precautions to minimise our risk to others and also our risk of getting it. And then we have the criminal law. Now, the criminal law in Victoria, step back. Globally, criminal law broadly in terms of HIV transmission, there are some countries in the world that specifically criminalise HIV transmission. That is, hone in, target HIV transmission. Then you have other approaches where we rely on general criminal law in broader offences such as insult and endangerment offences that could apply to HIV. It's not specifically targeting it, but it could apply. And this is the case in Victoria. So there used to be a provision, Section 19A, and that was introduced in 1993, and that was in response to a series of armed robberies where there was incidents where one incident where there was threatening with syringe and passing on, HIV. That was a different time. That was when HIV was very much considered a death sentence. We didn't have those precaution measures. So it took into 2015 to repeal that offence. And I must say that offence wasn't HIV. It was HIV specific. It was framed as intentionally causing a very serious disease, but that very serious disease was HIV. It was defined as such. And so specifically targeting that, you can see how that stigmatises it, because it is suggesting that it is a death sentence. And that particular offence had a maximum penalty of 25 years, which was out of kilter with other offences, with manslaughter, etc., etc. So it was really targeting, and you can see how that can perpetuate stigma. So today we have general criminal law provisions. So provisions relating to endangering someone or assault. So actually causing a very serious disease or threatening, and then ranging different from intentionally to recklessly, etc. So it's not, again, the case that it specifically targets, but someone can theoretically get prosecuted. The idea is when you see these guidelines is that the criminal law is supposed to be used as a last resort, right? It's supposed to be there as a deterrent. That is the goal of criminal law in general, as this kind of stick. But the question remains, does it actually is that happening in practice? And what is, even if it's not happening in practice, we know that there's been the estimates range, but it's around about 53 prosecutions. But even if it's not necessarily resulting in a prosecution, what does it do when that's there? And that's the regulatory environment in terms of stigma, particularly because when you're focusing on the criminal law, in order to fall foul of these offences, you need to be, it kind of punishes the HIV positive person because they need to know that they have the disease to pass it on and to meet that criminal standard. So what it does is it kind of deters testing because it's punishing someone who's actually gone out there and got tested. And what we know is that people who actually take those proactive measures and get tested are the least likely to actually pass it because they're already engaging with the preventative measures that they need. In most cases, there's always exceptions. So you can see how it's really punishing the HIV positive individual as opposed to the public health response that's really focused around shared responsibility. So again, in principle, it sounds pretty good. You know, you've got a supportive system, increasingly progressive, but to the extent in which that operates in practice or to the extent in which something that is still criminalised, what that does to stigma, what that does to view, that attributes blame, how, you know, if you're implementing a technology like this, how that can be weaponizing data or you're constantly under threat or fear. You can see how that can undermine the public health response and the public health benefits of such a technology.
Thank you. I think a round of applause. So now we've got the really interactive session and part of this evening. So we've got, so I should introduce myself first. I'm Dr. Megan Munson from the Melbourne Medical School, but also from the Children's Research Institute. And I'd also like to thank the panel again for such a fantastic picture that you've painted of the complexities of this issue. And I would open the floor for questions. I've got some prepared. And we're also very happy to take questions from our colleagues who are joining us online. But I'm going to start by just asking the panel a very kind of broad question. I think you've each shown how this project has evolved and how it's probably benefited the field and I think the community. What about you as individuals, researchers, as people in the community? What impact has this kind of project, this opportunity had on you?
It has completely changed the way that I approach research, I would say. I wrote a fellowship earlier this year, which was around sexual health and similarly what we do with looking at transmission, in that case, syphilis, which is a huge emerging issue in Australia. And part of the fellowship was around community engagement. How do we identify would this be acceptable? How would it actually look in practice? Which communities would be involved in how, that type of thing. So that front end bit, which as a biochemist, I had never approached before.
George, is that the first time you put something like that in the grant?
Absolutely, yeah. And I feel.
And were you confident in doing it?
Yes. Yeah, I've spent a lot of time talking to community groups through this project and through projects since, and I feel like it is important that someone is across both sides to be able to speak to the technical aspects, but also to have the community, voice and speak.
Well, how has it changed what I do? Okay, well, this has been my first formal role in public health research. So, full disclosure, Megan actually supervised my PhD, which was in sociology. And I suppose in a lot of ways I didn't find sociology a natural home because I felt a lot of the work that I was doing was quite abstract. Whether a blessing or a curse, when COVID hit, I was out of a job. And so I studied public health so that I could move more formally into this space. And it's just been so incredibly rewarding to see, and I absolutely maintain that I've not told Richard a single thing that he didn't already know from, the data collected from the interviews, but seeing this interview data being, I guess, the value of it in being able to tell the stories behind these concerns and, writing up this paper, I feel like it's really meaningful, impactful work. So it's, I guess, renewed my love of qualitative research, and it's just been so rewarding working with community and, such this incredible partnership.
I guess from my perspective, I had the privilege of going to Germany this year for the International AIDS Conference in Munich. And it's the first one I've attended. And it wasn't until I got outside Australia that I really did have that realisation of how well we do it here. The fact that people living with HIV and folks like myself have the privilege of advocating for their community at every level of the response. We don't always get what we want, but that's part of collaboration. And it's really made me talk to my community about leaning into the success of HIV in this country. For so long, I think people living with HIV, whether it's because we've been othered or seen as failures, having contracted HIV in the prevention space, haven't really lent in to what we've been able to achieve. We're a huge part of that success story, whether it's having the courage to disclose to a partner, whether it's adhering to your medications over a long period of time and maintaining viral suppression. All of those key things have played a role into getting where we are in this country with our HIV response. And we're looking at virtual elimination in a very realistic way. And people living with HIV want to be a part of that. I'm hoping that one day I get to walk out and close the door behind me. And I think this type of engagement is really the foundations that have got us to where we are.
Hey, can you elaborate a bit more about what you found or what you saw when you went to the conference in Germany? I'm curious to know, what were the key things that you saw at this year?
It was really confronting for me, the sense of privilege that I felt when I arrived there. I've kind of always known that we're engaged in world's best practice here, but always just focused and determined. I want better, we can do better, why can't we be first, all that kind of stuff. And when you get into that environment, and even other wealthy countries don't have the same type of organisations that I lead, and Living Positive Victoria, run by and for people living with HIV, who have secured long-term government funding and support over a long period of time, who have an opportunity to be involved in fantastic collaboration of this nature. And I was doing a couple of peer workshops over there with other organisations, and they're all run on volunteers, and even in countries like Germany and sometimes in the UK, they're organisations that used to look like mine have gone and not been replaced, and a whole range of other things. And so
Is that for funding?
I think it's funding, yes, and funding pressures are here too. We've just all received 15% funding cuts to our forward grants and things like that. So it's always at the front of mind. But even with those cuts, and as challenging as that might be to absorb them, we still have the foundations, the history, the resources, the connections to be able to achieve fantastic things.
And I think also perhaps the history, like you've achieved. And I think, I come from a very different part of science, and we look into what we've been able to achieve within the HIV community as, quite startling. For all those things you mentioned before about advocacy, how we, and also collaboration, how we can inject that into medical research more broadly.
Yeah, and I hope it's a model that is seen as valuable and has applications in other areas as well, with patients being at the centre of the kind of whole framework about how we deal with chronic manageable illnesses.
Now, any questions in the room or online? Because I'm just going to segue from that point then, because there is a change around philanthropy, but also government bodies where, community partnership, community involvement, whatever acronym or name you want to give it, but this kind of engagement is required. And I'm going to come to the weeds because I think, you've lived the dream really in terms of a project that's involved, and it's involved because you listen. But, was that, what were the circumstances that enabled that?
Yeah, I can be a bit cynical about science at times as a sociologist, and you always feel like you're you're down the pecking order science. There's a real science, and that's what we do. And I think what was really refreshing working with the Doherty was I didn't feel like that. I actually felt like it was a genuine partnership, and there was no sort of sense of hierarchies or jostling. It was like, if this is the work that needs to be done, that's what we're going to put the money, and that's what we're going to do. And I found that really refreshing, and I don't think Simon's always operates like that. So yeah, it was a really great example of an agile collaboration. But and I'm not sure. I don't know if it's a Doherty thing. I haven't partnered with a Doherty before, but I would definitely partner with them again. Because I've certainly been in other collaborations that are much more rigid and don't follow the community voice.
Might just second that by before I applied for the work with Louise, like informally asked her, is this just a box ticking exercise? Because I sort of shared similar concerns. As a qualitative researcher, I often harbour concerns that, I'm asking people to share really deep, personal experiences and, what sort of duty of care do I owe to that data? And so that was my concern. But I remember one of the first meetings with Jane Hocking, and she just said, "Oh, thank God you're here."
That's certainly a warm welcome.
Yeah.
Penny.
Hi everyone, hi people at home. My name is Penny Gleeson. I'm an academic focused on public health law at Deakin Law School. I know government was one of the partners. I'd be really keen to hear about impressions of their involvement, what their position is currently and going forward, to the extent that I understand it.
Yeah, it's a good question. And I think COVID was a really big factor in government partners changing pretty regularly. Jack, I don't know if you want to comment, but it was a sort of moving beast as to who was involved. The person. So it was the same sort of position. So yeah, we had some really great engagement, but it would be like we'd have them for 6 months and then there'd be a new person. So, and I think COVID and I think the budget cuts in the Department of Health in Victoria really affected that. But whoever was there was very engaged, but we just didn't have that consistency of personnel over time. I don't know if Jack wants to add anything.
Yeah. As Louise said, I guess over that time we had 3 different people as the principal epidemiologist for STIs. That was the main person, that was the owner of the data and the process behind some of that, as well as different chief health officers too. We did invite them here tonight, but the person that was our main contact has just left the role. It's restructured. That team has restructured for the 3rd time, so it's been involved. Which I think is an ongoing challenge for them as well. And one of the questions that's been brought up is, what is the public health able to do in the restrained constrained environment? But it has been incredibly useful, I think, to have in the table, even when they can't act, to listen, to help us as well understand from their perspective what they can and can't do. And I think sometimes those partnerships between different bodies aren't always there. We were able to do that this time, have the government in every meeting, and they did come to every meeting, at least 2 or 3 of them from different levels. We at the start had the policy team involved, the policy team, the restructure, and got taken out. So we didn't get to replace that position. But for a while, we did have the policy, epidemiology, and clinical advice in the department all in the group, and that has changed over time.
And just a point of order, so Jack didn't introduce herself, but that was Jacqueline Prestige. She's been our project officer, manager, people corraller. And so, yeah, if you want to know part of how this collaboration has worked, it's because Jack has kept everyone talking and on the same page and showing up to meetings. And so thanks, Jack.
And I'd also like to acknowledge the government engagement with it as well. I think that other jurisdictions have gone ahead. I know it's been implemented in other jurisdictions without community consultation. I'm not sure what the outcomes are going to be long term as a result
When
of
is
that. Maybe 12 months ago, I think it kind of started rolling out, which kind of put some added pressure on our group and kind of, gave us a timeline that we kind of needed to kind of come up with some ideas in a bit of an ethical framework that Casey and others have started to kind of work around. But that government support just does show a genuine commitment to that partnership in an ongoing way that, again, when you go overseas is quite a unique Australian model. So,
Is you trying to make a comment or a question?
Question I hope. and presenting with a tiny bit of quite short. Emotional. So I'm a lived experience community researcher at the moment, and just would be good to give a little bit of context. Because I started out as a geneticist and molecular biologist and worked in this community socialized tutor through the Genome project with Welcome. I had some experience of developing governance models there. I'm interested to kind of just congratulate the group because it's like you coming together and doing this work is hard. I'm applying for a couple of grants and sort of like looking at spaces like this at the moment, and this is hard to set up. I'm interested in, and I get the discussion around criminalisation. I was president of the Post Victoria, it was my bag, and with Richard on the board as well, we carried through the repeal of Section 18A and bringing that through, and that was just one part of what needed to be done. So I get all of that. I'm actually more interested in the social and political and commercial determinants of this technology, and sort of, it seems to me that it's shifted. And so are there any comments or observations or need for further research perhaps from the panel? So, obviously COVID has an impact on public perceptions, the performance of the Department of Public Health in Victoria, and the limitations of what we saw happen to the rights of minorities and those concerns about information, etc. Politically, we're in a time of financial constraint, and so I can't see. I'll be honest, I can't see this getting up before another election at the present time. So I think it's a political aspect to something and a risk-averse government. And my bigger, so are there any observations around this political or social? Because that would be really interesting. You've been looking at this and you must have thought of things. And my bigger question is, what does this mean for researchers and groups like us when we're trying to co-design or think about governance models? Because this is coming up time and time again with technologies. I'm working on this in digital mental health and algorithms and AI, and other researchers will be working on this. So how can we work well together? What have we learned from this project in trying to do this kind of co-design or collaborative work? Because it's very hard to do, I would say. Congratulations on getting as far as you've got.
The politics first, please.
Okay. Look, I think we really do have to have a look at, is it going to be cost effective for the numbers that we're looking at? I know it's been applied and, historically it's been applied in clusters of 3s and 5s and other things like that, which may be effective and it may reach some people from communities who may not believe they're at risk and may not test in a regular way. Or can that money that might be allocated to setting up this kind of framework be better spent on supporting better engagement across our sexual health system and having a look at that? We're kind of all clustered in Melbourne sexual health in the city here. Could those monies be better dispensed in supporting regional or hub and spoke models across the state, which might have a better effect in getting people to test regularly and do a whole range of other things? So I think the political climate is challenging. I know that there is some discussion at the national level that the larger states may have the numbers to go and make this an effective kind of application, but already some of those smaller population states are just looking at it and going, no, we don't want to kind of spend the time and resources. And one thing that has been missing from this is an indication of cost. I don't think at any stage we've kind of had a real clear determination of what the cost is going to be to implement this. And then what happens? Yeah, and then what happens? And I was talking before about budget cuts, and it's, you have to be pragmatic really quickly when you get budget cuts across your organisation, and it's broader than HIV, it's across the whole community services sector in Victoria. But I think if we do start using this technology, we have to talk about governance. We have to talk about who does what, where, and why as a result of the implementation of this. So is our community organisations expected to do more with less and pick up the support for these new people diagnosed by this really unusual and emerging technologies who will have different kinds of impacts on being diagnosed via this technology than the traditional routes? the shift in focus to priority populations that are driven by this technology. Where do those resources fall? Who do they go to? How are they engaged? We haven't quite got there yet, but yeah, I think they're all really interesting questions, and it's been, I believe, even if we don't go forward, I do believe that it's been a really valuable situation, and I wish you every success with your grant, Ian. And I know that in mental health particularly, we were talking about community involvement after the Royal Commission in Victoria and lots of funding going towards mental health. I was absolutely thrilled to see that lived experience is absolutely key to people attaining those new pots of funding. You have to show lived experience engagement in your organisation. And I think that if those innovations with new funding come with community being centred at it, I think that we'll be better off regardless of, even if there's a reduced amount of money on the table, we'll be better.
Please.
Yeah, I think there'd have to be a pretty strong champion, probably in government, who really wanted to push this forward. And I think there'd have to be some, really partnering with the community to say what's in it for you guys, putting in perhaps more testing, different types of testing at the same time, and potentially having it as a really transparent model of actually you'd have to trial it and see is it actually going to make any difference? Is it going to, if you could prove that it was really going to pick up extra cases and that those could be managed well, and if the cost wasn't astronomical, but I think it needs a sort of trial period to see if it does actually deliver on what it promises and whether the community are happy with it. But it would need someone really, really championing it, probably from within government, and I don't see that happening at the moment.
Did that issue of cost and allocation of resources come up in qualitative research?
Yeah, lots of talk of just spend the money on testing, don't spend it on.
And maybe education, I think it was
stigma-free testing.
And that kind of regional, we're very metropolitan focused out there in Victoria.
Yeah, but I guess in terms of the cost, there was also, the big bet is spent on professional development for medical professionals to have an impact on the stigma environment in the clinical setting.
There's not to be a defensive public. I just want to raise that the sequencing that the method is based on is done routinely anyway. It's not as routine care where the sequence part of the HIV genome sort of resistance, trying to guide treatment. So the data exists. A lot of the concerns around the data and how it's being used will be there regardless of if we use it for something. Yeah, exactly. So there should be a little bit of separation there. And the actual time and effort into looking at the modelling is just pushing button on the computer once it's set up. It's about the public health action that's linked to that. And I think it's a discussion out of my hands. It's actually out of a lot of people in the tables' hands, but you can tailor that. So if you are in a budget limited environment, you can say, okay, let's have a response or whatever. And if you are awash with public health funding, then you can throw everything at it. Yeah, exactly. Anyway, thanks.
I think another question, I think.
Hi, my name is Shelley Mackey. I'm with the School of Vision Global Healthcare. And my question is for Richard. You mentioned your decision not to be a full partner on the project, and I'm wondering if that is a useful model for giving you agility to advocate, but also how it affected the partnership and what you think might have happened if there were diverging opinions about what it should look like, and if you could just reflect on if you recommend that.
I think I had the privilege to make that decision because another partner who was supposed to be here tonight, James, representing Thorn Harbour Health, they are funded to do most of the HIV prevention in Victoria. We have a very close relationship with them, and we kind of had a little bit of a sideline discussion, which might have enabled participation as well as the opportunity for us to sit outside and do that advocacy and kind of really advocate full-throatedly in the public sphere if we needed to do that at some stage. So it was quite strategic in a way. Having said that, the moment that I signed that letter of support and we got the grant, I was all in. So I've been, you know what I mean, I've been a willing participant in this, and I've learned a lot along the way. The people that I've worked with here and all those people on the panel have engendered complete trust from my perspective in my engagement, and what I've learned and being able to maybe disseminate sometimes quite technical information down to community conversations about what it is. And I think it links back to what you were just saying, that I start that premise when I engage with my community by reminding them that they've already had this testing done, that when we get our follow-up test after a diagnosis, we get this testing done to ensure that we get the most effective treatment and that we're not having resistance to some treatment that we might be to put on. So I have let people know that that's the basic understanding that they have. At the beginning, I think it was good to use COVID as a reference, but as we've gone on and we've kind of gotten to where we are, I don't say the C word anymore, because there seems to be, the further we get away from that immediate kind of situation we had in Victoria, the more you're realising that people were extremely traumatised by it, and that trauma is just still starting to tickle up now. So whilst I would have, at the beginning of this process, spoken about this is what we did to achieve what we achieved in COVID, I would not be taking that engagement with my community now. But I've also spoken to them, and I think sometimes there can be a misconception because I advocate so hard, but positive people want to see the end of HIV, every single one of us. I think we had 238 diagnoses in Victoria last year, which was a bit of a bump after a bit of a lull during COVID.
In previous years, like what?
Oh, they've been higher in previous years. We've seen steady declines, and I expect to continue to see those into the future. But what's left behind is populations that don't look like me.
Yeah.
They aren't men who have sex with men that are community connected. They're heterosexual women. They're heterosexually identified men. They're migrant communities. They're people that are coming here sometimes with advanced HIV under refugee programs, or young students who are contracting HIV here because they don't believe there's any risk in this country. A whole range of kind of smaller populations that haven't really been serviced in the way that people who look like me do. And that was some of my concern about this technology and the potential stigma that could be directed at them as we get closer to that virtual elimination number. And I really do believe that we will attain that in this country, perhaps in the next decade or so. But as we get closer to that, who's left behind in that number? And does that focus of stigma then intensify on those individuals? And if we're just short of making that magical 91 number, which it is, who gets blamed for not achieving that? Do you know what I mean? So I've still got some concerns, but certainly the strategic partnership we have with Thorn Harbour Health enabled me and Kirsty Maker from Positive Women to kind of say, we might sit this one out. But once we got this grant, it's just been an absolute pleasure to participate.
Just listening to you talk, Richard, the quote that we've chosen to kind of lead the article, the publication is that these kinds of, one participant said that these kinds of technologies can seem warm and fuzzy until they interact with other forms of marginalisation. So I think,
and politicisation.
Yeah.
Casey, I want to come back to you around the regulatory frameworks in other states and Australia. I'm just curious to know, it's great in Victoria that we've got an opportunity to think deeper about this. It sounds like it's not the case elsewhere, and you've also looked internationally. So I'm just kind of curious as to know again a bit more about how this issue is addressed elsewhere.
Yeah, so the Australian framework, there's nuances against different jurisdictions in terms of how they regulate them. But I think Victoria in general has a pretty good approach, particularly its public health approach, because it's focused on the shared responsibility. We do see with other jurisdictions, again, there's no HIV specific events anymore in Australia, but there is the emphasis on different public health acts on whether there's shared responsibility or there's individualised responsibility. There's some variation there, and then there's also interaction with other laws in terms of how they affirmative consent laws and how that, I'm not going to go into that today, but in terms of how these other laws that might necessarily be specific to HIV, but they interact and they have effects unintended. And I think it goes back to the point, Richard was making before. We are in a pretty, if we can consider globally, we're in a pretty good legal framework in terms of, we don't have that same targeting as you see in international jurisdictions. We have specifically focused on HIV, is specifically criminalising that. But that's not to just say that we become complacent just because we've got a pretty good framework. And I think what the conversation needs to have is we are very much focused on law here. But law is great, but it's not all of regulation. And I think that's kind of, we focus on regulation and we see these kind of law as this command and control mechanism, and it has all the coercive power, and that's the only form of regulation. But regulation is much broader than that. And I think we need to look broader. We need to think about policies. We need to think about guidelines. We need to think about what other mechanisms we can implement to kind of have the same outcomes and, try and achieve the same things that law is trying to achieve in terms of deterring undesirable behaviour that leads to increased transmission, in terms of protecting population. But we don't necessarily need the law to do that, and we need to look broader. And the advantage of that is that we can implement some of those changes now, because we don't need that. This is quite political. Yes. So if we're not going to achieve law reform, then what can we do now? And also, talked about the R word, the resourcing. Sometimes, some things will take resourcing if we look at other measures, but sometimes it is, you can implement more cost-effective things. It's about changing societal norms, and, you use education, and every time you say education, people kind of roll their eyes. It's like, well, we've been trying to educate across stigma for years and it hasn't worked. And that's a complementary measure, and, we need to, it's about, educating the population and continuing to do that. Just because it hasn't been effective, it doesn't mean it stops. It means that it needs to be done in conjunction with other things. So I think I've just gone off on a tangent.
I will come back to policy in a sec, but would you?
I was just going to say, we positive people support the health response in Victoria, that staged response. I'm not Pollyanna. I understand that. That's from time to time we have people with really complex intersectional issues which have poor outcomes on behaviour. And that through that model, at the top level, after you've exhausted all opportunities for behavioural change and connection to taking that personal responsibility, the Chief Health Officer can still refer somebody for criminalisation for their actions at the top of that. What we don't like is the criminal law aspect of it, and I feel in some ways safer in Victoria. We've seen other states, and it seems to run contrary to the biomedical advances and the actual reduction in risk that has happened over the last 10 years. We've seen what we call spitting laws, which is mandatory testing laws in Western Australia. New South Wales being proposed in Queensland, being proposed in South Australia, just the last few years. And Western Australia in particular, I think 393 mandatory tests have been imposed on people for spitting. It's anti-science, it's anti-data. You cannot contract HIV by saliva.
Sounds very conceived, selling well in some political circles.
Well, it is, and it's driven largely by unions for frontline workers. And please don't get me wrong, I respect the work that they do, and they have to come up against all kinds of hostility and behaviours when they're engaging in their day-to-day work, and that work should be safe. However, it's not based in science, it's not based in evidence, and we are concerned that we're seeing more and more of this type of reaction that potentially impact those people on the very margins of society the most. And so I'm very relieved that Victoria hasn't headed down that track, and there doesn't seem to be any signals at the moment that they are. But even progressive governments have supported that legislative change in those states, and that's concerning.
Casey, so you've said policy could be the way forward, some guidelines. What would you like to, maybe the way of, if I grant you some powers, what would you
A lot. I think what needs to, policy can be very powerful if you target the right people. So I think, if we're talking about education and we're talking about policies and procedures, it's a way of practicing. So if we are going to, prosecute someone, if we are going to rely on this technology in legal proceedings, etc., we should be targeting those particular people who might not be familiar with the technology and look at, policies of, before you do that, let's have a conversation with the, health department. Let's have, memorandums of understanding that we are only going to, we're only going to engage the police in those kind of really desperate, situations. But I think also, in policies in terms of how we report on this, it's not just targeting, people in law enforcement, it's more broadly, how do we report this in media? How does that fuel, stigma, etc.? So we're talking about these, if we implement this technology and we're talking about clusters, we need to be able to have policies and guidelines about how we report this in the media, what kind of misconceptions might be there. So I think,
Has there been much, I don't know how the media has handled this issue. What's the media representation been like?
Yeah, we were going to do media analysis. That was one of the studies we proposed, but there just really wasn't enough to justify it. It really hasn't get much out into the media so far.
But I think internationally, like in some of the North American jurisdictions where this technology is implemented for this purpose, so HIV surveillance, there's a couple of studies that have come out and they've talked about the media impact and how that perpetuates the stigma because it's just misreported and people, think about this technology used to indicate directionality, etc., etc. It can't do that, but how it's reported, and it goes down to the fear, and it goes down to what we were talking about before. This is great if it has the intended effects, but if you're scaring people off, you're kind of undermining that approach. So you need to have these complementary measures, and you need to deal with some of the more systemic issues.
It sounds like a good one, I suppose, is to coordination. To that your dream policy.
Did give me all the power.
I just want to read a comment that's been put in the online Q&A. And I think it's seeking to emphasise the work that is already done that avoids coercive control. So it's a comment from Jane Hooker, and it's in relation to the Victorian Department of Health, the Victorian Public Health team, which has a very small specialist team of experienced nurses who are partner notification officers for HIV, called the VIX team. 4 nurses who manage all referrals regarding people living with HIV and provide advice, do investigations, chief health officer and HIV panel. Jane notes there are sadly a very small minority of people who often have other social vulnerabilities, but the majority of work that they do is not about using coercive measures. Instead, applying the least restrictive methods of reducing risk to self and others. So I think this James is quite keen to make that point, acknowledging that, as you say, that there is going to be a need for a range of measures, but just to acknowledge that the team currently do see coercive measures as the last result. But this is possibly going back to your point earlier, Casey, in relation to perceptions and fear, whether it's well grounded or not. If there's a fear that people may be subject to criminal action, then even if that fear is not well founded, that can be discouraging, potentially discouraging from seeking help.
Thanks. That's actually a perfect segue to my question. So I'm Sid, I'm Roger, I'm a bioethicist working in infectious diseases. And I'm interested in, do we have transparent reporting in Victoria about how many people are on behavioural orders? I was interested if you could quote the numbers of people with mandated testing in WA. Do we transparently report that information in Victoria? And if not, why not? That's my first question.
Jane looked online.
You'll find that in the back of one of the appendices of the Department of Health's annual report that was published a couple of days ago. Very hard to find, it's very hard to decipher. I've tried to do it myself. So I'm just saying you'll find it's tucked away way at the back, and there's no breakdown at all. Please.
That was 53.
One or two a year.
One or two.
Is in the CHO report only one or two a year? Right.
Yeah, thanks, that's great. And then I have another question about the status quo, just maybe for George and Casey, which is that George, you mentioned some of this sequencing is already done for the purpose of diagnosing resistance, but we don't necessarily need to share this data with public health, right? So visual or whichever lab it is, we just tell the clinicians what's the resistance profile. We don't need to share the sequences. We just have 0 or 1. Are they resistant or not to the treatment based on the genotype? And public health never need to know. I don't know what the Public Health Act says about reporting HIV diagnoses, but it's a pretty old act, and I'm sure it mainly says that is if it's positive or not, rather than the sequences. I'm not sure. There's a question about status quo. And so there couldn't be an option where we don't share this information with public health. And related to that, when we had the state of emergency, all bets were off. If a public health officer says that there's a serious threat to public health, they get anything they want. Any bank details, police to bash down your door, anything you want. What can they get right now? So the public health, say we don't implement molecular surveillance, all of it, and the public health officer just asks for the sequence data and get it based on the public.
I was just going to say, I think that was the emphasis they should have helped me.
Fantastic questions. I agree that they could just refuse to share that data with public officers. I think that's a possibility. I think the concern in a criminal setting is different, and that it could be required that they pass that on. And that is the main concern of the community. So I think that's where the focus should be. Yeah, exactly.
Can't subpoena or whatever get it from visual instead of from public health agency. So as someone else raised, it makes no difference whether we do molecular surveillance if the data are there and who holds them, if they can be subpoenaed or whatever the appropriate legal mention is. Can't they get that already?
Well, the purpose means it needs to know what to do with the data and to run the model and that type of thing. And so I think that's a missing component. It's more that they subpoena the output of the model and say this person is linked to this person, which is a concern that we've discussed. And it would be, if it was even implemented, which it hasn't been, to make that clear in Victoria at least, there would be controls around who has access to that level of data, and the sequences themselves would be largely kept in public health in the lab setting there rather than with another agency. That I think would cover it, but there's always going to be issues around, is this efficient? Is this, the right people that have control over the data at the moment? I think having it in a public health surveillance lab is appropriate. The team there are very much focused on public health, not on criminal prosecution of people, but yeah, that's my take.
And I just want to go back to that online. I didn't mean to upset anyone. Right? But I guess just to frame the discussion, it gets back to, it's about the perception. So the public, and framing the discussion in the beginning, is that the public health response is pretty good, and the advantage of it being in that is that they have these wonderful people who work there and can connect people with supports, right? And in that's what you want in most cases, but it's the perception of not necessarily understanding how that works that deters people from testing and getting connected with those services. So I do not want to upset anyone. I do acknowledge that it exists, but I think it's about the fact that because criminal law remains there, there's always that attached stigma, whether it's right or wrong. It doesn't matter how rarely it's engaged, it communicates something. And I think that's really, really important because, particularly when I came in this project, again, dip in, dip out, but it's this idea of, I feel a little bit like an interloper, in terms of recommending a regulatory framework, because I've never lived the stigma. I've never lived and breathed it. I don't know what it feels like. And the fact that people still feel this way, despite the amount how we've progressed, we need to acknowledge that. And it's not to undermine anyone's brilliant work, but we just need to understand that there will be people in the community, rightly or wrongly, who feel that stigma and, feel that they can't engage with these measures.
So just to clarify, if the chief health officer tomorrow says that they're concerned about a growing cluster, do they have a legal power to ask the lab for the full sequence data? Now, I know not everyone can read those data, but just suppose the health agency had something that could. Can they request the data right now?
I think,
I can't answer that. I don't think it's ever happened. I think it's one of those, it would be your first case. I'm not sure how it would go down to be honest. Yeah. Sure.
I realised someone had some information. So Brett Sutton gave the Thorn Harbour address about 2 years ago, and he's just stepped down as Chief Health Officer, and he expressed some disquiet with how what we call, I'm going to say, sorry, Richard, we call it the Naughty Boys committee, because of the way, because of how it's sort of perceived by community. So I think he expressed to Thorpe Harbour at that annual general meeting a feeling that if he had his time again, he would want to look at the operation of that. Parallel I would give you around governance is the controversy here from almost 20 years ago around newborn screening blood spots, when all over the age in about 2002, 2003 after investigation. But that was the national blood database that was being stored forever and could be used for any purposes, and there was no governance around it. And there's disparity between how newborn blood spots, those ones that are taken and just used, but how they're used in further research, and there are access sometimes by the police and also in criminal cases for identification. In some states, there's a memorandum of understanding, so there's active opposition. To answer your question, quite finally. So there's active opposition from the people who hold that data to giving that up, and then obviously a court order is found. So I would say in a governance model, would there be active legal resistance to, and it would be transparent what the reason was, and it would be tested in a court as to whether this was appropriate or not. So I think that's what we'd be looking for, the governance model I would be looking for.
So I think there's a very good point about whether or not anyone would actually resist, and whether there would be actively resistance. But the other point which Jen Booker's made in the online forum is in relation to the data that's actually stored. So of course, even if you have the legal power to access the data, you can only access the data that's kept. And Jane knows that we don't identify cases by name in Victoria in public health. All public health records for all STIs only use a 2x2 name code, not even full name. It's only when VICs open up a case file we use a name, and these notes are only used by the VICs team, not done for full words. So there is that issue about whether any order to release would be resistant, because also the question about what actually is retained in a way that could be accessed even with authorities to do so. Okay, well, I think we're going to have to bring this to a close. Thank you all very much for your contributions. Clearly, there's a lot of learning that can be shared when people have success in addressing an issue and learning in relation to how that can be applied to other contexts as well. So one of the things we're keen to do in Collborative is look across at how things are done in one place, because we can learn how it might work in others. And this clearly is an extremely powerful example of how collaboration can work and the value of consumer and public engagement. In my own work, I'm interested in notions of trustworthy governance, and I'm not going to go on again, you don't have time. But one of the really important elements of trustworthiness, as I understand it from the literature that I read, relates to being able to articulate to people why they should expose themselves to the vulnerability that they do expose themselves to when they trust. So what's the value proposition you can articulate that gives them a reason to trust and gives them a reason to take the chance on you when they trust you? And so being able to articulate the governance that actually means that there is benefit and there's value from the individual as well as the community level, so that they can have confidence that when they do share that data, they are not exposing themselves to an unjustified vulnerability. it's a very, very important thing. It's through the consumer engagement you identify those perceived risks. And if you don't understand the perceived risks, realise the perceived risks and you're guiding the motivating action, you can't put in place the responses. So you've worked to identify risks and you are now working to work out how do you respond. So fantastic. So please join me once again and thank you to the panellists and thank you for the conversation tonight. Those are appreciation to say thank you very much. Yeah, when we started the company, our hope was that over time we might be able to make some kind of contribution to the conversation that would allow for regulation to improve improvement in care. And that's just the kind of conversation we've had tonight. So thank you very much. And I look forward to seeing you at future coverage events next year. Thank you once again. Have a safe journey home. Thank you.